Yes, Joe.
How would this not eventually lead to rationing of health care?
Ah, excellent question. I can't promise that it wouldn't eventually lead to rationing, but there are a couple of things built into it. I'm saying, first of all, I am not putting a federal budget cap on anything. I'm saying the compact, and it ought to be something deep into a very public, very agreed upon compact. You can't write it into the Constitution. It takes too long to get it approved. But it sort of needs to be something that deep. The first thing is, I truly believe that there are a lot of people who are getting medical care they don't want. What happens is, if you get into the healthcare system, once you get beyond your primary care physician, it's like getting on a train that's leaving the station and you didn't have time to check to see where it was going. And you discovered that it was an express, not the local. You can't get off. Often what happens, and this is not because I think physicians are evil or money grubbing or anything else. I'm starting with the assumption that particularly specialists do what they do. They're very good at it. And they make a reasonable assumption that if a patient was referred to them by a primary care physician or just came in the door, they know what they want. So with those orthopedists as an example, they're expecting that a patient coming to them wants an intervention for their back. Let's figure out what people want. Let's figure out, is that better? Thank you. And let people start making choices. On the physician side is they will start asking what really works for my patients. They can spend time to explain why you don't need that drug that happened to be advertised on TV. Okay? And as those things start happening, the developers of the interventions, the new drugs, the new devices, etc., will change where they're investing. I mean, I've talked to venture capitalists who say, we will not invest in any new technology that does not have a physician fee attached to it. Because essentially, when a physician fee is attached to their intervention, the physicians become the marketing team. You turn that around, and all of a sudden, that venture capital money up on Sand Hill Road will start flowing somewhere else, towards interventions that reduce cost and enhance quality. So I don't know that we will ever necessarily, I can't promise that we won't start rationing, but I'm trying to change the system incentives to move towards facing that choice much further down the road than we are now. Sandy.
Yeah, I think as a health economist, I could see how this is very appealing to you. My question is, who would implement such a program? Is this a national program that the government would implement, or a state program?
Okay, to really work, it ought to be national. But the only national federal government stuff that needs to happen is essentially some enabling legislation. The universal coverage pool would be a public-private agency. And everything else is basically in the private sector. It's changing the structure, it's changing the incentives. One of the things one of the transformations I went through in thinking about this issue was, why not make it a single-payer system? What we have with a single-payer model is the ability of all the special interests, who are much more targeted than any public, than the public per se, to exert their influence on decisions. And those special interests are not necessarily the insurance companies. They're the subspecialty societies. They're the folks who make those surgical screws that cost $10,000 that you can't get at Ace Hardware. It's things of that sort that will get played through in a single-payer system. So that's why I'm trying to keep the government out of it. So, and actually, the one thing that I don't like about the cover is it probably should have been one red pill and one blue pill.
Where does prevention come in all of this?
Prevention. We don't spend very much on prevention in medical care. It's about 4% of the total expenditures on preventive services. The real preventive part is not so much the immunizations. No, sure you want to cover that. But changing diet, changing exercise, building walkable streets, changing transportation patterns. These are not in the healthcare system. These are things the public ought to do. They're public health, they're in transportation, changing agricultural policy so you don't subsidize corn sugars. There are lots of things that we can do to really do prevention. The universal coverage pool would be willing to pay for some of those things if it's really going to save them money down the road. Again, one of the problems here is I'm trying to keep out of the special interest situations. If you say, well, of course, you have to cover everything that's preventive, right? So does that mean we also cover digital mammography, which is now shown to be not as good as the old kind of mammography? Well, GE would want us to cover it, and you could be sure who'd be, pounding the halls of Congress. We just need to be a little more careful about that. Prevention is helpful, but let's not write a blank check.
If you said, well, the doctors can charge whatever they want, you're putting a lot on the patients to know who is more cost-effective in a way.
So if we had all of the current claims data, you roll it up and you say, well, how much is being spent by Dr. Welby for all of his patients? You adjust for age and sex, and you could then say, okay, for a typical 55-year-old male living in this area, seeing Dr. Welby, what's the annual premium going to be? Versus the typical 55-year-old male seeing Dr. Kiley in this area.
So there are cheaper doctors for your premium and more expensive doctors. Your premium will be different. Yes?
Yeah.
Okay, so that's a big switch.
I didn't tell you I was going to keep the thing the way it was. If we keep it the way it was, it doesn't change. It's radical. It's essentially saying, now remember, it's not higher or lower because Dr. Kiley has all the patients with chronic illness. That's been factored out because the money's coming in to cover their chronic illnesses. It reflects Kiley's practice style and what Kiley chooses to charge. He's got multiple ways to change that. He could start changing his referrals and spend more time talking to his patients. You may actually find that's a better way to practice. He can learn. This is continuing education. Last one.
A good deal of the cost of the current insurance system is in the adjudication of claims.
Right.
Now, do you get rid of that entirely?
Does Visa adjudicate your charges? I mean, on all those little ambulatory care visit charges, it all basically comes back to the patient. We're saying, if you're happy with what you got, that's okay with us. The payment intermediary is not an adjudicator unless you want to ask them to be. Okay, so again, that's a huge amount. The marketing cost of all those payment intermediaries becomes minimal because they're only marketing to the doctors. And they're not marketing very often. It's only when a doctor's unhappy are they going to change. So huge changes on the marketing side. Okay, and I think I've gotten the this is about time sign. Katie, thank you very much, and thank you all for coming.